Continue. All right, it's 8 o'clock, so we can go ahead and get started. My name is Kelsey Brown. I'm one of the staff pathologists at Coplow. Welcome to rounds. So I have 2 cases I'm going to go through. The first one is the globe from a 1.5-year-old male castrated kangaroo. If I can grab the history. Here we go. So this is the left eye. Clinically, they described it as ophthalmic plus minus exophthalmic with severe exposure keratitis resulting in a suspected chronic corneal perforation and desiccation. And those are kind of the main findings. They said for the contralateral eye, they had a very limited exam, but it seemed to be within normal limits. So here are the gross images of that globe. This first one, we're just looking at the cornea head on, just showing this desiccated cornea. And there's a lot of tan tissue kind of stuck to the top of it. Hard to say if there is a true perforation. When we hemisect it, it seems like there is some intact cornea here. And we're not seeing any other changes associated with the possible perforations like synechia or iris prolapse, but we can look at that more histologically. Other things in kind of the episcleral connective tissue and kind of where there should be orbital adipose and other connective tissues, it's been replaced by this kind of firm tan tissue instead. It's a little hard to make out the normal architecture. And there's the optic nerve. There should be an optic nerve somewhere here, but it's been kind of enveloped and obscured by this tan tissue back here. Otherwise, the remainder of the intraocular structures are relatively normal grossly. So we can go ahead and look at the slide. Right. Yes. Right. This is one of our extra large slides. Just briefly on our subgross view. So we have the cornea up top. Here's our little iris leaflets kind of in the middle. And we can see that definitely there is some element of corneal disease, as maybe we guess grossly. It's a little bit busier in the stroma at the periphery. And then up here, there's just this kind of large crust sitting on top of the cornea. Now, do we have an intact stroma here? So it doesn't look like in this particular section that there's a perforation. As we move back, there was a lens at one point, but it got kind of chunked out, so artifactually it's missing. But the iris leaflets look pretty good. As we move back further, the rest of the intraocular structures aren't particularly exciting at the subgross view. Then as we move back into where there's that tan tissue, kind of in the orbital region, there is indeed tan tissue. And there's kind of these areas where there's more purple, so increased cellularity, and they're kind of outlining these well-demarcated zones. So we'll look at those a little more closely. And there's also these little cavitated regions that also looks somewhat more cellular, so there's more purple. And then right here, this is our optic nerve, so we did catch that in section. So let's look at this more closely. All right. Focus, there we go. All right, so the globe's been rotated now. The cornea is going to be on the right. Posterior segment will be on the left as I move this way. But we'll just start with our corneal changes. Focus. There we go. So in the axial to paraxial cornea, superficially, this is formerly stroma. At this point, we've kind of lost the normal architecture of the collagen. We're not really seeing any distinct keratocytes. It's just kind of this zone of desiccated cornea. And I'll point out now, there's some folds in the cornea here. Just go ahead and ignore those. That's just artifactual. Try to kind of stay away from them if I can. And then outlining these areas of corneal desiccation, there's just a ton of intact and fragmented neutrophils. And as we move up to where corneal epithelium should be, it is gone. So this is an ulcerated area of cornea. And there's this large crust on top that's just made up of probably serum, a bunch of fragmented neutrophils, and little pockets of bacteria. So these are cocci. It's a little hard to make out on the screen here. And then there's also some foreign material, so hair shafts. I think somewhere there's some plant material embedded within this crust somewhere. Yeah, like this. this kind of brown linear structure, this little circular thing. So just some foreign material hanging out in this crust. As we move away from the ulcerated region, epithelium's pretty hyperplastic. It's a little bit keratinized. Get a little closer to show that even, which is just a non-specific finding. And then all the way up to the point of that ulcer, we have pretty robust vascularization and fibroplasia of the stroma. So a lot of these small caliber vessels. There's increased numbers of spindle-shaped cells. We also have a lot of neutrophils kind of hanging out in here too. All right. And then moving back, as I've already kind of mentioned, the anterior uveal tract is pretty unremarkable. We have a fragment of lens. Hard to say much else about that. A little bit of inflammation in our choroid. It's kind of a mixed population, mostly lymphocytes and plasma cells. There's some scattered neutrophils in there as well. And then while I'm here, we can also point out a normal structure of the marsupiali. So here, let me back out one more to show where we are. So we're at the optic nerve head right here. We can see the retina on either side, and kind of emanating from the optic nerve head, there's this tuft of vessels. They're kind of going a short distance into the vitreous here, and then they're also extending a very short distance through the nerve fiber layer. Then the rest of the retina is relatively avascular. So normal finding in a marsupial, but kind of just a fun feature. All right, let's actually look at the orbital tissue. So within our what should be the orbital adipose, there are these cavitations filled with neutrophils that are intact and fragmented. So we do have an abscess going to these zones here. So we have these areas where we can see some normal cellular and stromal architecture, but it's hypereosinophilic. We can't really see nuclei anymore. There's kind of just the loss of the normal staining. So this is consistent with coagulative necrosis. And kind of at the periphery of that, we just have this zone of neutrophils hanging out. And then if we go into the more viable regions, it's just composed of kind of fibroplasia and granulation tissue. So we have all these small caliber vessels. They're lined by plump endothelium, and there's just a bunch of just collagenous tissue that is being laid down. And within these zones of necrosis, there's also bacteria. Dun, dun, dun. Can go even one closer. Yeah, so we have these kind of filamentous bacilli within our areas of necrosis. And that's a pretty repeatable finding. We have another little slice of tissue here. We just got kangaroo. I don't have a specific breed of kangaroo or species, I guess, not breed. What's that?
Like a tree kangaroo versus a larger.
Your guess is as good as mine. It was a pretty large globe, so yeah. So you can at least say that.
So repeat
Oh, yeah. The question just was what kind of marsupial, and all we got was kangaroo. It was a larger globe, so presumably, yeah, not a smaller species of kangaroo. Yeah, so these filamentous bacilli are scattered all throughout these areas of orbital necrosis. And we did do a gram stain. Somewhere I have a dot, so you're not seeing a sea of yellow. There we go. They're gram negative. But maybe not focusing the best, but these are the bacteria. Y'all to believe me. All right, so I will switch over. Those are kind of the main findings to our diagnoses. So our major finding was this pretty profound orbital cellulitis with necrosis. It did also spread into the extraocular muscles, so there was a myositis. And then we had these filamentous gram-negative bacilli, as well as fibroplasia and abscessation. So all of this is probably the reason for the exophthalmos described clinically. And then secondarily, we developed a keratitis, likely due to exposure associated with exophthalmos, and then just secondary bacterial colonization of that ulcerated cornea. So at this stage, we can't really say much else about who these bacteria are. We mentioned that culture would be needed of tissue and asked that if they did end up culturing the tissue, we would love to know the results of that. Um, Kangaroos do like to get their own version of lumpy jaw, so they'll get facial and bony infections due to a variety of bacteria, but I think the one that's most commonly implicated is Fusobacterium, which certainly this bacteria could fit that. They are filamentous gram-negative bacteria. So we did kind of wonder, is there oral nasal disease? Is there facial disease elsewhere? And this is just extension of that bacteria into the orbital space. At this stage, just with the information we have, it's a little bit speculative. So they'll have to correlate clinically in this case, but kind of interesting case.
Mhm.
hmm
Where was it from again? Is that a zoo or a,
Um,
you don't say the name?
from a wildlife center.
Okay.
Cool.
We see that a lot in necropsy on these guys that have their chronic osteomyelitis.
With Fusobacterium or okay.
With their own variety of stuff.
Oh yeah, that's fair.
You see extension into the orbital tissue.
Okay. The comment here was that on necropsy of these guys, we'll often see extension of infection with a variety of bacteria into the orbital space, especially the ones that have a concurrent osteomyelitis. Sweet.
Oh, those are.
Okay. All right. Well, if there's no other further questions, concerns, I have one more. This one's kind of a short one. So this is going to be the globe from a dog. We have our clinical image here. This is a 6-year-old male castrated Schnauzer mix. Looks like a Schnauzer. And the history we got is somewhere on here. Here we go. Clinically, they diagnose hyphema and uveitis with a possible intraocular mass and yes to glaucoma. And the other eye is normal. So here's our clinical image. And what we described grossly, we can see part of that here. So we said that there was a tan mass affecting the ventromedial iris, which likely is this right here. Concurrently, we also described a tan mass over the dorsolateral equatorial sclera, which we can't really see in this image, and they didn't describe clinically, so probably it's getting obscured by the adnexa up here. All right. Anymore. All right, so same as before, cornea is on the right, posterior segment is going to be left. And there's kind of two major things to show. So one is going to be this large anterior uveal mass. Here it is. And the second one is going to be kind of this more vague mass effect in the dorsal episcleral tissue. While we're on low power, just show a couple other findings here. There is a cataract. I can go closer to show that. There is this kind of collagenous membrane that's lining the dorsal ciliary body. Our retina is detached, and that membrane is kind of lining part of the epiretinal surface. On the other side, our detached retina is also peripherally torn. We can see this kind of blunt end here. And there is intraocular hemorrhage. We have a lot of retina, actually. Goodness. Don't know what happened there. Yeah, right. Duplicated retina. In our torn retina, we also have these kind of clear spaces within that outer plexiform layer consistent with retinoschisis. And I can also show that a little more closely. But let's start with our masses. So this first one is kind of lining the anterior surface of the iris. There's areas where it looks like it's maybe infiltrating the stroma and it's occupying a good amount of the anterior chamber ventrally. And it's kind of creeping into the sclera, maybe the peripheral corneal stroma to some degree. And then kind of a classic neoplasm in a kind of weird location. So spoiler, this is neoplastic. We have this homogeneous population of round cells forming sheets, and they're pretty monotypic. Go even one closer to show them. And they have these kind of round to oval, very central nuclei, and not too much atypia. There are some mitoses in here. I forget what my mitotic rate was, but they're here and there. Maybe that's one right there. It's kind of condensed. And they're also interspersed with a ton of eosinophils, all of these little guys with the bilobe nuclei. So this in any location would be very, very consistent with a mast cell tumor. It's kind of a weird site for mast cell tumors. We don't see intraocular mast cell tumors very often. But there's that first one. And then we'll go to the episcleral mass, which has very similar findings. This one's very eosinophil heavy, but still we have this homogeneous population of brown cells. Mast cell tumors, we do expect to see cytoplasmic granules. I will say, as of late, I feel like our staining hasn't really highlighted the granules very well, at least in the ones that we've gotten at Coplow. I don't know if anyone else has noticed that. Okay.
Yeah.
I haven't gotten
Okay. Yeah, like maybe this guy has granules, but otherwise the morphology, the eosinophils is very highly suggestive.
We had a spell not too long ago where H&E was almost as good as tall blue for some mast cells.
But yeah,
But you're right, not
lately, I don't know. Yeah, they almost look like cat mast cells.
I asked Cody about it. He said if we change a little bit the pH of some of the reagents, that might cause some minor changes.
Interesting.
So
Okay. And then something else we see often with mast cell tumors is these little flame figures. So this is collagen that's been broken down. We have all these eosinophils surrounding it. They've laid down their major basic protein. And so we'll see this kind of radiating hypereosinophilic material, which isn't specific for mast cell tumors. We can see it with any eosinophil heavy lesion. So we have that. And before we kind of talk further about that, just show some other findings here. So they did say yes to glaucoma. We have a large mass in the ventral iridocorneal angle. And dorsally, we do have this kind of thin fibrovascular membrane, and it is causing peripheral anterior synechia. So we do have a couple good secondary reasons for glaucoma in this case. And then looking at this membrane, we have more of these little kind of scattered round cells and eosinophils that kind of spread all throughout the membrane as it goes over the retina as well, and some hemosiderin-laden macrophages. We do have a cataract. So there's posterior migration of the lens epithelium. We have formation of these Morgagnian globules and some bladder cells. So all hallmarks of a cataract. And then lastly, our detached retina. There's some atrophy of the inner and outer photoreceptor segments, which, if we were doubting it at all, helps corroborate that this is a true retinal detachment. And then on top of that, we also have retinoschisis. So just this separation in the outer plexiform layer. And due to the detachment, we're unable to confirm glaucoma in this case. There's this distortion of the optic nerve head, so we can't see a true cupping. And with detachment, we won't see that inner atrophy that we usually associate with glaucoma. Okay, so we have the intraocular and periocular mass, which we already strongly suggest is a mast cell tumor. I did ranitidine blue too, which is quite gorgeous. Here it is. And so Toledan blue is going to highlight the metachromatic granules within mast cells. So all of these really brightly purple granules, or granular-like things, are the granules that we see in mast cells. So this confirms that this is an intraocular mast cell tumor, as well as somewhere, there we go, an episcleral mast cell tumor. Here it is. All right, so kind of a straightforward diagnosis, but just an interesting one. I looked through our database, and there's really only a handful of intraocular mast cell tumors. I found like 5 or 6. And a lot of them we have limited follow-up. So it's hard to say if these represent, metastatic mast cell tumors that have disseminated to the eye. I think 1 or 2 of them did have concurrent cutaneous or subcutaneous mast cell tumors removed. So likely those do represent metastatic mast cell tumors. So in this case, we asked for follow-up saying, does this dog have a history of mastocytosis or mast cell tumor elsewhere in the body? We strongly suspect that this is probably a metastatic lesion, just given that we have 2 of them here in kind of atypical locations. The clinician did respond and say that, as far as they know, this dog does not have mast cell tumors elsewhere in the body. However, they do have several cutaneous and subcutaneous masses that haven't been worked up. So it's in the realm of possibility.
Right.
I think they aspirated a couple of them and didn't yield mast cells, but who knows? There could be one hiding elsewhere. In this stage, we just don't have sufficient information to say if this could be a primary tumor or not. But what's that?
Mastocytemia.
No, as far as we know now. Oh, sorry. The question was if this dog had mastocytemia, and yeah, weren't told if there was, but I assume they would have told us.
Right. I know that there's
Mhm.
there's this collection of them on or mast cell tumors on the conjunctiva,
Hmm.
but I hadn't heard of one on the sclera before.
Yeah, yeah. It's weird.
Well, I assume correctly or not that this is all part of an aesthetic disease.
Yeah, I mean, well, there's two masses.
Yeah, yeah. That was kind of our conclusion, the comment too, that maybe consider staging this patient to find a primary tumor elsewhere. But yeah, interesting nonetheless. I don't know. I wasn't expecting this with an intraocular mass.
Mhm.
Okay. And then here's the diagnoses. Just a lot of other little secondary changes. What's that? I did not grade them. I'm waiting for that paper to come out. A grading scheme for intraocular mast cell tumors.
Current scheme for all of the things.
Gosh. All right. I will hand over the scope to Dr. Kleinmans. Hey.
I'm Megan, and I've got two more cases for you. This first one is a bit of an unusual case. So we have a 5-year-old spayed female American Pit Bull mix. History is very short and sweet. Both eyes, they describe boothalamus, uveitis, and then progressing to early thesis bulbi bilaterally. Same history, both sides. And on our gross exam, the eyes look very, very similar, quite kind of symmetric. We have a thickened and very cloudy to opaque cornea on both. We have this severe distortion and thickening of the entire uveal tract, sort of tanned brown. Both lenses are looking cataractous, and the retina is kind of just lost in a mess of sort of cloudy vitreous back here, but suspected detachment. The only real difference is that there's kind of more overt hemorrhage on the left side, but otherwise they have pretty similar gross appearance. So let's take a look at what these cases looked like. So we can see this very severe infiltrate that is pretty much circumferentially inside the eye. Back here, I'll just start off up front, showing you how wrinkled the Descemet's membrane is, and this really, really thick fibrovascular membrane along the retrocorneal surface. So the wrinkling of the collagenous tunic, including Descemet's membrane, is kind of one of those features that suggests to us that this is sort of early thesis bulbi. It's probably progressing towards one of those shrunken globes, but at present is still, not quite as shrunken as it could get, essentially. And then looking around, the uveal tract is essentially just not recognizable. It's totally wiped out by this extremely dense cellular infiltrate. There's lots of melanin scattered about, which is of great interest. This infiltrate is very much centered on the uvea and most severe there, but it does involve a lot of surrounding structures. So it extends slightly into the sclera, and it does involve the retina, which is back here, all detached and weird looking, and hardly recognizable as itself, essentially. I'm gonna go over here really quick. So you can see from low magnification that we've got these kind of multifocal to coalescing regions that look kind of similar to one another. If we drop in on those, there's essentially a granulomatous to pyogranulomatous nature of the inflammation here. So a lot of these are essentially cores of necrotic debris and or neutrophils, often rich in melanin, which is interesting, surrounded by multi-layer epithelioid macrophages and then lymphocytes and plasma cells after that, which is a little bit weird. Basically kind of having like a pyogranulomatous or granulomatous distribution here. But other areas, it's basically just admixed macrophages, many of which are laden with melanin and lymphocytes and plasma cells and neutrophils. And then if we migrate along, there are areas that are just totally necrotic. This area is completely toast. We have some pre-existing collagen hanging out, and then there's just eosinophilic cellular necrotic debris and free melanin everywhere. Going back here. We can see that there are some areas where the retina is recognizable but really severely atrophied. So here's a segment of detached and very atrophied retina. And then interestingly, the inflammation really does involve the retina. It's pretty severe retinitis on top of everything else. As we're back here, we can also show off that more so in the posterior segment recognizably, there are these linings of epithelioid macrophages kind of along the intraocular surfaces. Here's a good example of that, actually. So an epithelial macrophage is forming a sort of carpet along some of the intraocular surfaces, but otherwise sometimes it's just severe distortion of the entire uvea. And the other eye looks much the same. There's not much else to say about this case. Certainly there's a really severe cataract in both eyes as well. So this is a really weird presentation, and essentially there's a couple of different differentials for this case. Basically kind of showing this case to point out cases in general that don't necessarily always fall into our nice little discrete boxes. Let's find like a more interesting area to drop down on while we talk about this. So because this case is bilateral and relatively symmetric, they didn't really tell us exactly what the onset was in one eye versus the other. Maybe this isn't as interesting to drop down on, but it's a place to drop down on. So bilaterally symmetric, they didn't really tell us what the onset is in one eye versus the other, but especially if it was basically synchronous, like both eyes presented with similar severity at the same time. And then because the inflammation is really centered on the uveal tract, it does involve a lot of surrounding structures, but most severe in the uvea. What I would favor most in this case is uveodermatologic syndrome, or VKH-like disease. There's certainly also a lot of melanin around and being phagocytized by macrophages. The issue is that melanin can be released from a necrotic uvea regardless. So if the uvea is necrotic for any reason, you could get melanin here and there, and it could be phagocytized by macrophages. So just kind of a melanin-rich or melanophage-rich inflammatory infiltrate doesn't confirm uveodermatologic syndrome in an eye. The other atypical features about this, we don't necessarily see as much collateral all the time with UDS, especially it tends to spare the retina. But the retinal involvement doesn't rule it out. And then it doesn't typically organize into kind of those granulomas, like those coalescent granulomas like that. Usually it's just sheets of admixed inflammatory cells in the uvea. So there are some atypical features for UDS in this case, even though I think it is the best diagnosis. And long story short, too late. This went out as a descriptive morph, so all those words up front are just a descriptive morph describing what we saw. And the other differentials for a case like this would be infectious, maybe especially a fungal organism. This patient hails from Ohio. There's a couple of fungi that you might want to consider causing ocular manifestation of systemic disease in that case. And then the third differential, I think, would be an asymmetric or asynchronous uveitis, essentially a really, really severe lens-induced reaction. The feature that is kind of similar to cases of that is the epithelioid macrophage carpeting along intraocular structures, and asynchronous uveitis can actually get quite severe and ultimately bilateral if you give it enough time. But I think ultimately uveodermatologic syndrome in this case most likely worthy of a couple of differentials. And the upshot is that it's probably worthwhile ruling out some infectious etiologies clinically, depending on their degree of clinical suspicion. Otherwise landing on autoimmune, and then basically all that you would have to do for this bilaterally nucleated patient would be to watch for dermatologic manifestations, which may or may not occur. So yeah, just kind of a weird case. And yeah, I thought it would be interesting to discuss a case that doesn't really fall into our discrete boxes so well. Um, okay. There aren't any questions or comments. We'll do the next one. Yeah, I think Kelsey grows this one. Yeah, this is a memorable one. She says, I did. So this is a 7-year, 3-month-old neutered male Singapura cat. Very cool breed. So they describe around the left eye periocular swelling and mild exophthalmos. Appears non-visual with absent dazzle and absent consensual PLR to the right eye. There's pain with resistance on retropulsion, a melting corneal ulcer, and they couldn't really see the back of the eye, but suspected there are posterior segment changes. Yes, there were. Um, so they were worried about trauma, especially a penetrating trauma and panophthalmitis or endophthalmitis in this case. Um, so on gross evaluation, we always get to see more of the globe when it's, cut in half like this. We do have a pretty cloudy and thick cornea, and then past that, there's this giant sort of tan white expanded area involving choroid plus or minus suprachoroidal space, probably a little bit of sclera as well, and spilling out a little bit into the orbital connective tissue. There's a little bit of similar thickening in the rest of the choroid or so, but mostly what we're looking at is this large area here, which is very much distorting the back of the eye. We do also have retinal detachment. You can see that detached retina through here. And then the vitreal space is full of cloudy gel, very high protein intraocular fluid. In what's left of the intraocular space, everything is sort of mushed to one side. Here's the optic nerve, by the way. So this thing is really distorting and smushing everything over to one side. All right. Let's see if we can't do a subgross on this one. Yep. B. Wait for it. There we go. It looks much the same as our gross. So we have a relatively quieter anterior segment. And then this large area that was tan on gross is, of course, very, very purple Gesundheit on histologic exam, supporting that this is a really cell-rich population at the site. And so this was grossly described as dorsal. We can confirm it's dorsal by finding tapetum, which is over here. So you can see the tapetum. So this is a dorsal area. We've got choroid essentially through here, and then choroid just melts into the cellular infiltrate. So it is sort of like posterior choroid, suprachoroidal or so in location. We maybe have a little bit of additional choroid over here, so maybe especially choroid. And then it does spill into the sclera and orbital connective tissue like we saw on gross. Sclera even becomes kind of indistinct in some areas. While we're on low magnification, there's this interesting area that's a little bit too purple up in dorsal bulbar conjunctiva. Very interesting. We'll take a closer look at that in a hot second. But let's address the elephant in the room first. I'm famous for not addressing the elephant in the room, so we'll change that. So again, just confirming up close our layers here. We've got a hyperplastic and hypertrophic RPE layer. Look at how cute they are. This is like tombstoning in half. And we have this high protein fluid in the intraocular spaces, which is why it was such a lovely gel set up on the fixed specimen. We have our choroidal stroma here, and then just melting into this area that is very much affected by a certain process. So roughly from here to here, we basically just have this thick fibrovascular lining, which is infiltrated by large numbers of neutrophils. And then there's neutrophils and macrophages kind of clustered along the inside of that. And then this just gives way to this giant cavitated space, which is filled with variably degenerate neutrophils. And we'll confirm that on closer look. Let's just walk slightly back to where we were. So kind of seeing a little bit of that fibrovascular nature here of the lining, macrophages and neutrophils in a central cavitation after that. So this is classic abscess. We have a cavitation full of pus and lined by fibrovascular tissue. If we look around in this abscess, we find some interesting things, which those may or may not be the ones I'm looking for. Hold, please. There we go. I like these ones.
Theme of the day.
Yeah. I thought this would go nice with the kangaroo. Let's see. I can't get it much more in focus than this, it seems. These are this lovely little pom-pom looking dudes. They have a sort of filamentous look, kind of clustered multifocally admixed with the exudates inside this abscess. Possibly if you saw these on like a gross unfixed specimen, they would present as like a sulfur granule type thing. Basically just clusters of bacteria, maybe plus or minus a biofilm that they're kind of making, like some matrix that they're making. They look kind of filamentous on H&E, although maybe not so much on this image. It's hard for me to get them in focus right now, but um, I did do a gram stain on this just for fun. See what we could get. There's a good number of them admixed. And there may be sometimes kind of more elongate bacilli or so, gram negative, or maybe filamentous. It's, kind of a variable morphology maybe. But regardless, we've got bacteria in here, as expected. They were also not acid fast, for what it's worth. Just curious. And then before we move on from this case, let's take a look at that suspicious area of conjunctiva. So the conjunctival epithelium is fused on itself ever so slightly right at the fornix, which is what we refer to as peripheral symblepharon, which could, in this case, just be a consequence of local inflammation. And then this is actually this narrow linear area of cavitation filled with neutrophils. And then we have maybe a little bit of a fibrovascular reaction in the surrounding conjunctival substantia propria. And we only really caught this area of kind of linear defect here, and then didn't quite catch an area where maybe it communicated with the surface or an area where maybe it communicated with this abscess.
Pointing towards the right location.
But it's pointing towards the right location, exactly. So the circumstantial evidence at least is strong. Strongly suspect that this could be a site of penetrating trauma, which may have been what produced our abscess back there. It is possible that this could alternately represent essentially like a draining tract. Basically, the abscess is bursting forth from the front. So I guess the question is this a path in or a path out? But ultimately, yeah, I think a penetrating trauma could absolutely have produced this abscess, which is what they were concerned about. The other possibility, just as Kelsey was saying for the kangaroo, is sort of local spread from like local anatomic affected areas. But it is such a cute little
It was dorsal.
inflated abscess. It's dorsal, yeah, and like so it's not likely to be oral cavity. I think contaminant penetrating trauma is more likely for this particular case. So yeah.
It's a beautiful suprachoroidal location, right?
Yeah,
It's
yeah.
Nicely.
It's nicely encapsulated. It's just sitting right there. Well, I mean, it does spill into a little bit around.
Right.
But yeah.
Point out how nicely it is under the choroid and between the sclera. Like
Yeah.
the exact place a place for a placement of like those suprachoroidal injections that people
Yeah.
are trying to get. Like
It was a super
scenario.
was a suprachoroidal injection of bacteria
Mhm.
by like a thorn or something, maybe. Yeah.
Yeah, because of the suprachoroidal location,
Yeah.
you might argue that there's a potential for systemic spreading into the eye, just because
It's possible.
chorocapillaries and chorocapillaries would be a little up high, but it looks so well delineated, and it really looks like a penetrating lesion.
Yeah. I mean, basically, long story short, like, there's a variety of ways bacteria can get to the eye. It's worth considering some, but, definitely a lot of things point to penetrating trauma.
So I lost money on that one. It looked like a very solid mass.
It does. It was a mass effect. Yeah. Very gooey. Wait. Kelsey says in the gross you can see the finger. Like there?
Right, yep.
Oh, fingerprints of a gross examiner. The gross examiner was here. All right.
It's called digital pathology.
Digital pathology. I love that joke. It's so good. Anyway.
Good job, Dad.
All right. Here's a more for you, and we'll move on.
Yeah, we're having too much fun. The university here is having so much fun, they're gonna start charging us instead of paying us salaries.
Oh my goodness.
Going down.
I hand that back to you. Oh, sorry,
It's okay. All right. Hi, it's Jamie. I'm here to present the last two cases for rounds. First up, we have a 2-year-old male neutered Chow Chow mixed breed dog with a history of anterior uveitis, glaucoma, resorbing cataract, lens subluxation, and non-visual right eye, all diagnosed in March of this year. They said the other eye is normal. It's been going on about 6 days. It also has a general medical condition of seizures. So grossly, we said that the globe was ophthalmic. We got the cornea up top. Here is our lens, which is looking a little bit more red and yellow than it should. So we think that there's maybe some intraocular hemorrhage occurring in this lens, which is important for this case. Our retina is detached here, kind of still connected to our optic nerve head here. And we have a lot of hemorrhage in this subretinal space. So, all right. Case, go this way. Ooh. Sorry, the globe is on the slide a little bit sideways. You can tell it was ophthalmic because it's kind of sneaking off the slide there underneath our slide cover here. So that's why it looks a little bit black up there. But we've got cornea. Here's our iris leaflets. We can kind of see inward kind of turning of the tips there. So we've got a little bit of entropy on UVA. Here is our lens. We've got a little bit of folding artifact. Here, so it's a little bit kind of chunky here in the middle. We'll just have to work around that. Here's that hemorrhage that's here. We can also see that there's this little plaque of stuff on the back of the lens that we'll take a closer look at. Here's our detached retina and all that subretinal space hemorrhage. Again, then connecting to our optic nerve, which also has a good amount of hemorrhage in it. Right. So again, since the globe is on the slide a little bit sideways, it's going to be a little bit differently oriented. So our cornea is down here on the bottom. We got a little bit of vascularization and maybe some neutrophils coming in here. Here is our iris. And again, as we saw kind of on our subgross, we've got our inward turning of our iris tips here. So some entropy and UVA, and that's being caused by this fibrovascular membrane that is traveling around the front of the iris this way here. And then it is also crossing our ankle here and causing some peripheral anterior synechia. If we move over to our lens, there's a little bit of hemorrhage here on the capsule. Get a little bit closer. We can also see some more spindle cells and maybe some blood vessels on the front of the anterior lens capsule here. So we have evidence of some posterior synechia. We can see some cataractous change here. So we've got our rounded up lens fibers that don't have any nucleus. So we have some more ganglion globules. Here is that hemorrhage in the lens. And if we move backwards a little bit, we can start to see some like hematoidin pigment, this yellow stuff here. Maybe some of it's a little bit more brown looking, so some hemosiderin. And some of our degenerate lens fibers also maintain their nucleus, so they have some bladder cells. And then I'm going to come over here to try to avoid some of that lens artifact. And so I'm going to come out here, is kind of, at the equator here, and we are going to notice that our lens epithelium has posteriorly migrated, which is also part of our cataract formation. Again, here is our hematoid-laden macrophages in here. And if we keep following our lens capsule here, posterior lens capsule, it gets kind of wrinkled, and it gets very serpentine. Again, more macrophages, and then it kind of blends with this collagenous plaque here that is filled with blood vessels. Here they are. And a little bit of osseous metaplasia here. And we've got all that blending here in the back of the lens capsule, intraocular hemorrhage. So this is pretty suggestive of persistent fetal vasculature. The retina is diffusely detached. Sometimes with this condition, you can see retinal dysplasia, but that wasn't really the case with this one. There is some variable atrophy, mostly associated with it being detached, and probably some of the some glaucoma changes, since we do have blockage of our angles up front with the membrane and the synechia. Got lots of hemorrhage in our subretinal space. And head back towards the optic nerve. The optic nerve head, there we go, is quite distorted by our detached retina, but we can still see some posterior bowing of our lamina curvosa, so consistent with our cupping, which would go along with chronic glaucoma, and then our intraocular hemorrhage. So like I said, this is most likely persistent fetal vasculature. This plaque of vessels and collagenous stuff on the back of the lens with the intraocular hemorrhage. I'll point to that condition. It's a congenital anomaly in dogs that is basically failure of like the normal regression of the primary vitreous body and the hyaloid vasculature. Not really sure what causes it to fail to regress, but normally it should start to regress and atrophy about 45 days in gestation in the dog, and be completely remodeled about, I think it was 2 to 4 weeks after birth. This is sporadically reported in like various breeds. It's usually unilateral. There are a couple breeds, the Doberman Pinscher and the Staffordshire Bull Terriers, that it's a hereditary pleomorphic condition, and it's bilateral in those breeds. And I think that was all the findings for this case.
What was the breed again in this case?
A Chow Chow mixed breed. So classic. Yes. So again, a conglomeration of lesions, the lens capsule continuity with that plaque there of vessels and collagen, intralenticular hemorrhage, consistent with persistent fetal vasculature, and the severe intraocular hemorrhage and synechation and stuff leading to secondary glaucoma. All right. And then my next case is very brief, but I brought it because it has a very dramatic clinical photo as a fair warning as I move over to our next case. So this is a 1-year-old mixed breed male intact dog. And if you haven't figured it out, here's our nose, here's our mouth. Here is a pair of clippers here for, I guess, size measurement. I guess they didn't have a banana maybe, or a cucumber for reference. It's an internet thing. But the elephant in the room, I guess, as Megan would put it, is this giant stick that is pointing out towards us in this left globe in this young dog. And came with a history of trauma, large stick penetrated OS, no glaucoma, one day history. So
We don't usually get a history of trauma, but if we didn't have a history of this one, I would have been very disappointed.
Yeah. They did.
Still some backstory, Nathan.
Yes,
Absolutely.
it would.
Yeah.
I would like a little bit more detailed trauma. Like, is he running through the woods?
So the diagnosis is ligneous conjunctivitis, right?
But ligneous conjunctivitis. Ha 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 ha. No. The other eye is normal, and
So Erica Line said that she proposes that the clippers are holding the shaggy hair out of the
oh.
Good, yeah.
I like that.
I like that as a definite possibility. I love it. Okay, so
Somebody interrupted the text as they were shaving.
Mhm.
yes, so I was all prepared. The clinician had emailed this photo to us and sent it to us ahead of time and said, "Hey, be on the lookout. I'm sending you this case." Mostly just out of fun. And so I was all excited to take this awesome gross picture for you guys of a stick in the eye. However, when we got the globe, it was not super impressive. So there was a little bit of some conjunctiva here on orbital tissue on the dorsal portion. They didn't submit the stick. It wasn't there. And which is a little bit sad, but they wanted the stick. I don't know. He did. The dog worked really hard for it. Maybe they give it back to the dog. Hopefully not. So grossly could not identify any true site of penetration into the globe. There is a little bit of intraocular hemorrhage. And most of the rest of the structures are fairly unremarkable. There's some congestion to the blood vessels in the uveal tract. And then we got a little bit of extraocular tissue, and we'll take a little bit closer look at that. So again, this was mostly for the dramatic gross photo. Not much going on in the eye. So again, hemorrhage in the anterior chamber, so a little bit of hyphema. This is probably a blue eye. There's not much pigment here in the uveal tract. Our lens was unremarkable. No evidence of lens capsule rupture. No inflammation in the eye. Our uveal tract, our choroid back here is fairly congested, but that's about it. Optic nerve head and optic nerve looked pretty well. Did in the orbital tissue, we did find some foreign material. So we've got some plant here and here. It's kind of fun. I will say there really wasn't much of an inflammatory reaction to it. So I don't know if this is just leftover pieces from what they removed. Let's see if I can. Oh. Oh. Is that in already or? Okay.
Yeah.
Oh.
To the side. And
See if I can. Oh.
I have to. So they're the other. I don't know which one it is.
Put that in the middle again.
Oh, in the middle.
Yeah.
Okay. Oh. Oh, actually,
Nice collagen.
nice collagen. Actually, if I can focus that at all.
A little bit.
So a little bit. So I think that the thing is that most of this is probably like just fungus. Did we get a little bit closer?
Oh.
So, and look, we can even go one more closer. So some of it is a little bit pigmented. We've got some conidia and fungal hyphae and just tons of little organisms in here, just hanging out. So, so despite a pretty dramatic clinical photo, the eye was remarkably not too bad. But it was still fun to look at and to receive.
So yeah, so basically an orbital penetrating foreign body, right? Rather than necessarily
Yeah.
ocular penetrating foreign.
Right. Yeah. So, like I said, the history said it would penetrated the left globe, but we did not find any gross or histologic evidence of it actually penetrating the globe. sure it sort of squished it a little bit of hemorrhage inside the eye and some congestion, and then a little bit of that, you know, organic material in the surrounding tissue.
Nerve lesions, any, no?
No optic nerve lesions. It was a 1-day history.
Yeah.
So they got to it pretty quickly. I imagine that was fairly traumatic for the owners, I would imagine.
Using its globe as a stress ball.
Yeah. So just a fun quick one to finish us out for rounds. So thanks everybody for joining us, and we will see you guys in 2 weeks.
Thank you.
There's 2 months.